Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 473 of our pharmacotherapy series, which majors in hematopoietic cell transplantation. In this video we continue to discuss the case of patient PKJ. My question to you reads: what are the goals and characteristics of agents used for myeloablative preparative regimens in patients like PKJ? The primary goal of PKJ's high-dose, myeloablative preparative regimen followed by autologous transplant is to eradicate residual malignancy that is not treatable with standard chemotherapy. With autologous hematopoietic cell transplantation, there is no need for immunosuppression because the donor and recipient are genetically identical. Combination chemotherapy with multiple alkylating agents constitutes the most common high-dose regimens before autologous hematopoietic cell transplantation. Alkylating agents are used because they exhibit a steep dose-response curve for various malignancies to overcome resistance to treatment, and are characterized by dose-limiting bone marrow suppression. Ideally, combinations of antineoplastics should have non-hematologic toxicities that do not overlap and that are not life-threatening. My next questions to you read: what complications must be anticipated as a consequence of autologous hematopoietic cell transplantation? How can these be minimized? How can treatment be provided in an outpatient setting? The most common cause of death after autologous hematopoietic cell transplantation is relapse of the primary disease. The most common toxicities seen during autologous hematopoietic cell transplantation are the result of the pancytopenia induced by high-dose chemotherapy. Because autologous hematopoietic cell transplantation is not complicated by profound immunosuppression or graft versus host disease, supportive care strategies differ from allogeneic hematopoietic cell transplantation. Isolation and use of laminar airflow rooms are unnecessary. The use of autologous peripheral blood progenitor cell transplantation is associated with shorter periods of neutropenia and less need for clinical resources. Thus, some hematopoietic cell transplantation centers have developed programs that incorporate outpatient care into the initial recovery. These outpatient programs also offer cost savings to the payer for health services. Successful outpatient care during autologous hematopoietic cell transplantation requires careful development and implementation of the necessary supportive care strategies to prevent or minimize infection, chemotherapy-induced nausea and vomiting, infection, pain, and transfusion requirements. It is also necessary to develop admission criteria for patients with more severe complications. Use of prophylactic oral antibiotics and once-daily IV antibiotics to prevent or treat febrile neutropenia has facilitated outpatient care and prevented many patients from being hospitalized. In addition, outpatient care during autologous hematopoietic cell transplantation demands that hematopoietic cell transplantation centers have appropriate resources, facilities, and staff to provide 24-hour patient care coverage. Patients undergoing outpatient care must meet eligibility criteria, including the availability of caregivers 24 hours a day and housing within close proximity to the hematopoietic cell transplantation center. 10 days after the collection of peripheral blood progenitor cell, PKJ is admitted for his autologous hematopoietic cell transplantation. He receives a myeloablative preparative regimen with cyclophosphamide, carmustine, and etoposide with an autologous peripheral blood progenitor cell graft. An order is written to begin fulgrastim 5 micrograms per kilogram per day subcutaneously, beginning on day 0 and continuing until the absolute neutrophil count has recovered to 500 cells per microliter for 2 consecutive days. So my question to you reads: what is the rationale for fulgrastim in PKJ after the transplant procedure? Autologous hematopoietic cell transplantations, regardless of the stem cell source, are associated with profound aplasia due to the myeloablative preparative regimen. Aplasia typically lasts 14 to 21 days after an autologous bone marrow transplant and 10 to 14 days after an autologous peripheral blood progenitor cell transplantation. During this period of pancytopenia, patients are at high risk for complications such as bleeding and infection. In order to lessen the complications of pancytopenia, hematopoietic growth factors, such as fulgrastim and sargramostim, may be used. These drugs exert their effects by stimulating the proliferation of committed progenitor cells. The benefits of the hematopoietic growth factor have been shown in several large multi-center, randomized, double-blind, placebo-controlled trials. The majority of the trials suggest hematopoietic growth factor administration is associated with a shorter time to neutrophil engraftment, by 4 to 7 days, less infectious complications, shorter hospitalization after autologous bone marrow transplant, and therefore decreased resource utilization. However, the use of these agents does not affect overall survival. Although studies in the autologous peripheral blood progenitor cell transplantation setting note more rapid neutrophil recovery after hematopoietic growth factor use, others report no difference in infection rates and minimal decreases in associated resource use such as the duration of hospitalization. Although clinical practice guidelines for hematopoietic growth factors support their use after autologous transplant, pharmacoeconomic analyses are needed to further evaluate the true benefit of hematopoietic growth factors after autologous peripheral blood progenitor cell transplantation. Fulgrastim is preferred for accelerating neutrophil engraftment in clinical practice. The reason most commonly cited is the desire to avoid febrile reactions associated with sargramostim, which complicates interpretation of febrile neutropenia. Although sargramostim or fulgrastim theoretically may stimulate proliferation of leukemia myeloblasts, no evidence to date suggests that the incidence of leukemia relapse is higher in patients who receive these hematopoietic growth factors after autologous or allogeneic hematopoietic cell transplantation. Although both filgrastim and sargramostim successfully hasten neutrophil recovery, neither agent stimulates platelet production or augments platelet recovery. At this time, there is no established role for erythropoietin-stimulating agents or platelet growth factors in the care of these patients. In summary, PKJ is undergoing autologous peripheral blood progenitor cell transplantation for the treatment of a lymphoid malignancy. Thus, either sargramostim or filgrastim is an acceptable option for accelerating engraftment. Whether the addition of either agent will reduce infection and improve other clinically relevant outcomes is debatable. A complete blood cell, abbreviated as CBC, count with differential should be obtained daily. Filgrastim should be continued until neutrophil recovery is achieved. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 474.